Well, good afternoon, and thank you for providing me this opportunity to come and share some experiences about an alternate form of capacity building with ASHAs. Basically, in this presentation and the 10 minutes I have, I'm going to be looking at three things. One, talk about an alternative way of building capacities for ASHAs in an ongoing manner and provide them support. Secondly, share some results in terms of what we are seeing at the level of what's happening as a result of this intervention. And thirdly, to share some conclusions and observations that may be considered as policy options. So beginning, I would like to relate, there have been several points of, I would say, intersection in what I'm going to say and what I've been hearing in the last 2 days. More specifically referring today to Kabir's presentation in this session, we heard of the three challenges. Another way of putting it, and I come from IntraHealth, and there we are using it. I was suddenly reminded of that. Oh, it's the same thing. We at IntraHealth call it that if we are going to focus on the effectiveness of health workers, they have to be present, they have to be ready, they have to be connected, and they have to be safe. These are the four kind of pillars that help in health workforce strengthening and taking health workers to performance. I'm going to talk on two of these elements today in my presentation, and that is to do with making them ready and making them connected, because ASHAs are already present on the ground in the numbers that we want them. I'll skip this slide. Some of you saw in this morning. Vistar project works in UP and Jharkhand, and this work is in 8 districts of UP, so not much. The important thing is here, why focus on ASHAs? Primarily, when we are talking about newborn care and home-based newborn care practices, ASHAs offer us a tremendous opportunity. Evidence has shown that counseling during home visits is very effective in influencing household practices and community level practices. There is already existing evidence that supports that. In a state like Uttar Pradesh, ASHAs are providing critical antenatal and postnatal support to over 5 million deliveries annually. So look at the numbers that we are talking about and the opportunity for shifting some of our statistics. And finally, we do know that even after the initial training, quality and number of ASHA home visits were inadequate. The observation I'm making has been corroborated by what Garima presented in the ASHA studies, though UP was not there, from other states, that how home visits continue to be a challenge. So that's the reason why we focus on ASHAs. Another thing I would like to say is that one of my colleagues, Dr. Dharmen Pawar, was here in EPHP1. And at that time, he shared the approach of performance needs assessment that I'm summarizing here again in terms of what is the situation on the ground, why this is happening, what are the problems. There was a very structured kind of focus group discussions and in-depth interviews done by a large number of ASHAs across districts to find out what is the gap and what are the struggles. Some of the things that we found there was that ASHAs had the knowledge, they knew what had been taught to them, but transacting that into a family situation as a part of a counseling was a challenge. They were not able to apply or put it in application. Also, communication and counseling skills were a challenge. We all know the number and quality of home visits was low, but a very important part was that after the training, there was no post-training support, there were no job aids available, and monitoring was also weak. For UP, they run a very large program called the CCSP, Comprehensive Child Survival Program, and ANMs are also considered to be supervisors of ASHAs in that domain. But do ANMs have the supervision and support skills? They have never been supervisors. They have never been trained to be supervisors. And there is a lack of ASHA support mechanism. At the state level, there are just a few consultants supported by NHSRC, but any kind of a support structure at the district level, at the block level, or the sub-block level is almost absent, almost nil. So that's the kind of a situation in which we thought of this alternative way of providing capacity building and support to ASHAs. So what were the inputs? What did we do? One of the first important thing was that how do we create opportunities for continuing learning and supportive supervision? And one of the first thing we did was restructuring of ASHA monthly meetings. This sounds simplistic. What's there? ASHA meeting already happens. But typically, in an ASHA meeting, there would be somewhere around 200 ASHAs. What kind of communication would happen there? What kind of sharing would happen there? It's for anyone to imagine. The structure, the direction, purpose, and the communication in those meetings, you can imagine what would it be with 200 people in a, not even in a very large space, because there aren't that kind of spaces available at the block level. So restructuring of the ASHA monthly meeting was done, whereby we did an analysis. It didn't require any additional input. The same people who were present in that one large meeting of 200 plus people, there were negotiations with the district authorities to try and break that meeting into smaller groups so that about 40 to 50 ASHAs could be in one group, so that there could be better communication and more interaction. Also, the capacity building of block facilitators, because another big challenge is that in standalone kind of training, event-based training, facilitators come from outside, they train for a certain number of days, and they are gone. Whereas the system requires ongoing reinforcement, ongoing problem solving, ongoing hand-holding in terms of supporting the ASHAs. So the block facilitators, who happen to be people like few medical officers, health education officers, male supervisors, some really good communication, good skill ANMs and LHVs were selected on a very kind of a clear criteria to work as block facilitators. And then their capacity was built in participatory training so that they can continue with this kind of work. Building capacity of ANMs in supportive supervision and refresher on basic content. Because ANMs, to be able to support ASHAs, also have to update their content, because if they themselves are mixed up on the messaging, what kind of a support are they going to provide to ASHAs? So reinforcement on that, along with some input on supportive supervision, which was about respectful, positive relationship and non-authoritative communication, and kind of making supervision in-depth and systematic, or interactions in-depth and systematic. There's also developing 2-hour sessions which can be used at the monthly meetings. The second part of it is there was a simultaneous work to create a district level unit that will have the ownership and the leadership to take this process forward. Vistar is not going to be there forever. And some of these processes have to be nurtured, have to be taken forward. So already there are ASHA mentoring groups in the district, but we all know that the number and the size and the diversity of the AMG is such that it's not very functional on a regular basis. So a small subgroup has been taken from the ASHA mentoring group, and they have been provided support to take on leadership for this. Strengthen capacity of the technical resource group, we did that. And in terms of the scale, we are talking about almost 10,000 ASHAs and 1,900 ANM and LHVs, reaching a population about 17 million in 63 blocks. Let's quickly look at what are some of the results. And I'm in my last few slides. If you see, the attendance at these monthly meetings has continued to be over 70%. So there is a lot of engagement with this process. And in almost 90% monthly meetings, there is a capacity building session which is held. So ongoing reinforcement of skill and knowledge for ASHAs is happening almost at every monthly meeting, almost 90 plus monthly meetings. There's also an improvement in the A&M support for ASHAs for home visit. Especially A&Ms are discussing with ASHAs about home visits, finding about what they are doing, what are the kind of problems they are facing, and they are also reviewing home visit records. You can see the kind of changes which have taken place in the baseline and later. This is from our own internal MIS, but there are some external reviews also. ASHA is reporting A&M and LHVs as supportive. This is out of the Vistar MIS again. So there's constantly ASHAs are reporting A&Ms as supportive. And what does it mean to be supportive? It means they are engaging, they are finding about performance and in home visits, they are discussing problems, and they are offering solutions for those problems. These are the kind of criteria that we take for being supportive. What does it mean at the ground level? Newborn care home visits by ASHAs in the first 7 days have increased from 0.6% at the time of baseline to an end line, which is an external evaluation we did a couple of months ago in March, to 38.3. So there have been quite an increase in the number of home visits that ASHAs are making within the first 7 days of births. On the whole, this is just a picture of all newborn care visits. This includes ASHAs as well as other providers who are providing the support. And as you can see, there is an increase. But mark here, there's a marked increase in the second visit and a third visit. And the reason is that as compared to the baseline, in the end line in March, the external survey, the number of second and third home visits by ASHAs, the percentages have really increased. In the baseline, it was second visit was only 1.1, it has gone to 35.3. In the third visit, it was only 0.2%, it has gone to 24.9. So ASHAs have started making the home visit. What does it mean in terms of what is happening in the practices? Delayed bathing, you see, there have been marked improvements. Newborn being weighed at the time of birth, there is some shift. Nothing applied after cutting the cord before it fell off. We didn't have a baseline for it, but 35% are doing it at the end line. Newborns given colostrums, again there is an increase. No prelectals given, again there is an increase. And initiated breastfeeding within 1 hour, though we would have liked the increase to be more, but still there's an increase. So what does all this mean in terms of conclusions? Ongoing capacity building of ASHAs is critical to building their skills and confidence because they have to translate the technical knowledge into practice. Also, increased contact and improved message deliveries by ASHAs contribute to change in newborn care practices at the household level. Providing supervisory skills and tools to A&Ms can address essential support needs of ASHAs, especially in a scenario when there are no block and sub-block mechanisms for ASHA support. And Village Health and Nutrition Days provide a platform for one-on-one engagement between ASHAs and A&Ms. Restructuring of the existing monthly meetings for ongoing learning, reduce need for standalone training events. And finally, costs involved are minimal, mostly require leadership and time of the government staff. So we are not talking of a whole lot of parallel people or a parallel set of people to be doing this kind of work. Thank you very much, and I'll be happy for answering any questions.
Sir, I'm Dr. Siddharam from KL University, sir. My question is, nowadays ASHAs are demanding for permanent job and fixed salary. Even I noticed when I visited the Anganwadi during my study. Whether the appointing them and considering them as a permanent job holder or fixed salary is going to strengthen them or going to weaken them. And another one, regarding 21 days training, is it sufficient for them? Because repeated training is not conducted and it is not compulsory that they should go continuously for 21 days. They can choose like 2 days, few days, and how it is going to impact on them.
Dr. Khan, my name is Devaki, and my question was about other outcomes not associated with newborn care practices for which ASHAs are responsible.